Gloves. Ideally, you don't have to do the assessment with gloves on, but I want you to have the feeling of touching a patient with gloves on. Because it's a little bit different. If you're using your hands the whole time for your whole life, and then suddenly you got to put something else on, so there's a fabric between you and the patient, it might feel a little different, even though this is pretty thin. You're not wearing like oven mitts or anything like that. So you're going to come across the patient. Now this is the ideal circumstance. The patient is lying on their back. I don't have to roll the patient, which is most of the time what you're going to have to do. Most of my patients are usually between the toilet and the wall. All right, they fell down at 2 o'clock in the morning, so you're going to need an abundance of people to move them. It's never going to be this perfect. Or under a tree in the shade. And I ask the bugs to stay away for 5 minutes. I don't think they're listening.
I got a question.
Yeah.
The person is on their stomach or on their side. Like you said, what if there's signs of a head trauma?
Right.
What do you do?
You're going to take C-spine precautions. So for example, let's say there is something like that. So this, we don't know, this could be an unwitnessed fall from a tree. Chris is going to take C-spine precautions right now and hold their neck stability. The idea is, what's she going to do how did he not injure himself? Well, he could wake up and be startled by me or by Chris or by anyone else standing in a circle, and I'd be like, what's going on? And suddenly, whatever injury he might have heard, he just made it 10 times worse. So Chris is going to be there, so if he does open his eyes, or if I'm standing over him,
you okay? You died.
So you fell down, you hurt yourself. I'm Gage from Fairfax County Fire Rescue. I'm going to do an assessment on you to make sure that you're okay. So it's just me communicating with them, being like, I'm going to be touching you, or starting from your head and working down to your toes for a reason.
But if you got to roll,
We'll get back. We'll get to it.
Oh, yeah.
A little bit later.
We'll get there.
But it's a very, very good question. It's important.
And you guys can come closer. I want you to see what I'm doing.
But Chris is just holding his head in place.
Yeah.
It's not feeling for anything per se. She's just holding it
Just
steady.
holding it. See, her fingers are going to slide under her neck right there, so it's just holding the patient's head still so they don't move.
With my hands, actually, I would put his head between my legs, and then I could, because once you get this is your job.
Yeah.
This is your life. This is his head. So.
Whoever takes control of the head, they're there for the duration, for a period of time. It could be 15 minutes, it could be longer than that. But we don't know. In the meantime, their job is to not move. You can find something to replace them when the assessment's complete, but prior to that, we want to have someone engaged there, like holding it, or at least keeping it like between like 2 logs or something holding their neck stable so that we don't cause further injury. Not necessary.
And you do whatever you need to do. On one of our patients, I just had someone that was doing head control, grab their hair, and they held their hair to keep it from moving. Not to keep their head from moving.
Seems barbaric, but you want to keep them from hurting themselves worse. So it might seem like, why are they doing that? They're being so mean to the person. They're trying to keep the person from getting more injured. So I'm going to look at the top of their head. You can look at their eyes right now. Are they, what's the acronym is called PEARL, so pupils equal and reactive to light. Don't worry about the acronym. What's more important is when you look at their pupils, are they constricted? Are they blown out? Are they equal? Is one blown out and one not? Something off of your soap notes. And then you're going to touch their head. So what you're going to feel in their head is when they fell, does their head feel soft? Like, is it like what the professional word is crepitus in the head? So what that feeling is like, yeah. It would be like their head has a Rice Krispie feeling. Has anyone had the cereal Rice Krispies? I don't want to assume that. Not everyone has. Has everyone had? So the feeling, if you touch the back of their head, I mean, if you feel your scalp, does it feel pretty solid right now? Mm-hmm. So if something was like pushed in, or you've had, let's say, softer than usual, would that feel awkward to you? Those are the things you want to be aware of, being like, oh, that's another thing that goes in your soap notes.
Like, do not push in on it.
I was going to say, stop.
Yeah.
Stop
Sir,
right there.
Yeah, stop. Does this hurt, ma'am? No, I guess I shouldn't do that. Don't do that.
Right.
All right. Then you're going to check around their face, their nose. You're just not going to push on the nose, but let's say I push on his nose and he winces. Then I recognize, well, maybe he struck his nose somewhere. Maybe it's broken. You don't know. Maybe it's profusely bleeding, but it's something you want to take a look at. Then I'm going to look in your mouth, sir. The reason I'm looking at his mouth, does he have all his teeth? His teeth missing. And I'm like, sir, you go to the dentist often, you've got missing teeth. He might be like, yeah, I only have 12 teeth. I'm like, oh, okay, man. And I already know.
Some places in Virginia, that's
Yeah, some Vermont came up with the toothbrush, singular toothbrush. All right, I'm gonna look in there and see, like, you know, is the tongue? Where is the tongue? Can he speak to me? Is the tongue pushed to all the way to the back of the head, back of his mouth? Then I'm gonna look at his neck. Everyone can see this is an anatomically looking proper neck. If it looks wrong, like if you see any of this, like any of this shifted off to the side, his airway, that's significant. You would want to note that for your soap notes. You don't have to worry about what it is. It's just we'll talk about what it is, but you want to note that, oh, maybe he's got what's called tracheal deviation. This is the trachea, and it should go from the bottom of his chin down, and down to his sternum right here. If this is pushed off to either side, you know that something ain't right. And then you would check the back of his neck. So the idea is like, sir, does this hurt? And he could be like, yes, no, and then you're going to start tactilely touching him on his shoulders, clavicles. For the chest, you're going to palpate the chest this way off the sternum. So you're going to use this whole thing called the midline. You're going to palpate off of that. You're going to roll off of that, looking at him. So you're aware of what you're doing, but you're also, while I'm watching him, and as well as Chris is also watching him. So if I turn away for 1 second, and let's say I'm poke his belly button, he goes, ah, and then I recognize that either he felt that, or maybe it's significant pain in his abdomen. So there's 4 quadrants of the chest you're going to palpate. So here, and here, and here, and then here, in the abdomen, same thing. And I'm watching to see if he has any reaction to my touching.
Now,
right?
he winces when he does this. He's not going to keep doing it.
Yeah.
That's the key. Like,
Yes.
if you find something.
Yeah. And it's you want to do it one time thoroughly. So you feel something solid, then you want to recognize and note that for your soap notes. I'm not be like, does this hurt? And he goes, out. I'm not going to be like, does this hurt? Yeah. No, don't keep doing that, okay? Not only is it totally inappropriate, but I mean, you don't want to cause someone more pain than they already are. So
First, do no more damage.
yeah, you don't want to do more harm than.
No harm. First, do no harm.
All right. I'm going to check his hips. So what I'm going to do is I'm going to push down. I'm going to push in. Obviously, if the hip girdle is affected, these are things you want to also going to go into your soap notes. It's also going to go into. You're going to be thinking deeply on how to move them. Like, let's say if you're 8 hours in to your hike, or it could be, let's say you're 80 miles into your hike. How is that going to translate to you moving this person a distance? Because moving a person of this size a significant distance is work. I know someone said earlier that they felt like they were going 1,000,000 miles an hour. You might be going 1,000,000 miles an hour, but the patient movement is going to be very slow and arduous, especially the type of terrain, or if it's if the weather's bad, or if it's at night. These are all factors you want to think in. Like, am I going to stay and play with this patient and send a group out, or am I going to try to move this patient? It's all going to be up to whoever decides that. Now I'm going to check his arms, touching him, and obviously you're just touching him now. Let's say it's always good to try to expose the patient as much as possible. You don't want to cut their clothes off if not necessary, especially like if it's like wintertime. But if you can tactile, like, see under their their skin, or if let's say if they have a bloody mess arm here, don't just do this. Be like, oh yeah, I got blood over my hands. Well, where'd the blood come from? So physically touch the arm here and be like, yep, clear. Or let's say you find the arm, oh, he's got a significant laceration in his forearm. That's where the blood came from. And that's why my gloves are, you can have any color gloves. White's helpful, because then you know, like, when you touch somebody and it comes back and it's not white, you're like, something's wrong.
But if he's obviously bleeding from the arm,
Mm-hmm.
would you then cut away the material?
Absolutely. Once I've identified, let's say he's got a cut in the shoulder, we got a pair of shears, we would just cut it up and expose it. You
Just
don't want.
realize you have to adjust for the environment too. If you have to cut away, make sure you can reclose it later. Because if it's 20 degrees outside, you cut that away, and you create another problem. So you just have to use some common sense on there. Like, yeah, I can cut it away, but I gotta make sure I can close it later.
He's got one problem. You don't want to have hypothermia.
Yeah.
That's another problem.
Is this a primary or secondary?
This would be secondary. So primary is what you've gone on scene. You'd be like, oh, he's down on the ground. I'm aware of the problem. Is the scene safe? Did he fall from a tree? Are there other people around who witnessed it? Your primary is assessment. This is you doing it. When your secondary is when you get on scene, and can they speak to you? Can they not speak to you? When you touch them, do they give you any sort of reaction? I like to do my assessments down one side of the body, and then I move to the other side. Try not to reach over the patient or step over the patient. Sometimes I can cause more injury than whatnot, because we're all wearing like these comfortable shoes. You don't want to step off. Most of the hiking boots you wear sometimes might be a little more significant, and you don't want to step on something or kick someone in the face, or they get an injured leg and you trip over that. It's just not necessary. So things that can be prevented, do your best to prevent it. Feel the leg.
So when you come onto somebody and they're laying on the ground like this, try not to stand over, talk down to them. You know, you want to get down to their level, right? You want to make them relaxed, and I think it's very intimidating to have bodies, whole group. For me, looking up, it's intimidating, right? So from an injured person, just having you kneel down beside them and talk gently, even if they're not conscious, is helpful.
No. Yeah, he's checking for blood. He's checking for fractures. He's checking for bleeding.
That's what Chris is doing. Chris is doing the reassurance part.
Yeah.
Taking the mystery about what's going on for the patient, so they know what's going on, is huge. Keeps the stress down. Keeps them feeling much more cooperative now. It is why he's doing this. He's checking your ribs for broken ribs. He's checking your stomach to make sure nothing's bleeding. So he's on yeah.
Okay. So check his leg. Come on this side. Go back to the arm. Now at this point, I am going to have to reach over and grab his hands, but this is to do an assessment on him. Sir, can you squeeze my fingers? So he's recognizing my voice, and I've given him a command, and he's done it. That's significantly helpful. All right.
Are you also checking to see that the grip is similar on both sides?
Yep. I'm checking the pulse. Check the grip. All right, sir. Can you feel me touching your finger?
Yes.
What finger am I touching? Middle? All right, good job. So he's recognized the sensation on the middle finger of his left hand that's what I'm touching. Significantly helpful. That determines you've done an assessment. He also has the cognition of like, oh, I've given him the commands and he's executed the commands.
And Gage is not asking open-ended questions. It's not a yes or no. It's which finger.
Yeah.
Can you feel me? And they answer yes. You don't. That's right.
I'll say yes to everything right now.
They will. Well, and the same thing with like the name. You don't ask, is your name, Chris? You say, what is your name? Because they'll agree to anything.
Yep.
Other assessment. All right, sir, can you pull up on your feet? All right, can you push down on my hands? All right, I'm gonna check for like a pulse in both, which he has. Then you can take off your shoe.
If you cannot get the pulse in the feet, they're hard to
Sir, what toe am I touching right now?
Big toe.
Awesome. On what foot?
Right foot.
Excellent. So that's initially your initial assessment. You've gone